So this little mini lecture is going to look at some of the pharmacological management approaches, or options that exist for managing patients with cirrhosis. Okay, learning objectives are a little bit different. We've gone over most of these drugs in terms of their mechanism of action. I think what's important for you to realize is point two here, the rationale for why we would use these drugs in specifically the management of cirrhosis. Okay. So the first group of drugs that are clinically relevant include beta blockers. Specifically, we're looking at the beta 1, beta 2 non-specific blockers. And so there's really two that are mentioned for cirrhotic patients, and that is propranolol and nadolol. And that's really kind of going after portal hypertension, which can be kind of a driving force for the development of cirrhosis. The rationale for the non-specific beta 1, beta 2 blockers, obviously looking at beta 1, we see antagonism, we see a reduction or a lowering of cardiac output, and that's going to reduce the splanchnic blood flow. From a beta 2 antagonism approach, we're actually kind of preventing vasodilation within those same vessels, and we're allowing for unopposed alpha-1 vasoconstriction. And so because that's actually a therapeutic strategy to basically let the alpha-1 receptor be free and to allow vasoconstriction, which would of course restore perfusion, there's really no need to even talk about those mixed acting alpha-beta blockers like carvedilol or labetalol. They're not really indicated for cirrhotic patients. And so typically with cirrhotic patients, they have low blood pressure already, so you're not going to be aggressive with these beta blockers in terms of looking at the cardiac effects or the vascular effects. So we're going to start with really low doses. And then do understand that propranolol and nadolol specifically are substrates for the CYP3A4 enzyme system, which is, of course, of all places, the liver. And so these patients should not be on high doses for those two reasons. Diuretics are also kind of a key management strategy for the cirrhotic patients. Remember that cirrhosis produces an elevated aldosterone state. So basically you get a reduction in blood flow to the kidneys, and that stimulates that renin-angiotensin-aldosterone system. And so we, from a therapeutic standpoint, will want to supply something like spironolactone, which is an aldosterone antagonist, to counter those effects. And we'll also combine that with a loop diuretic, specifically furosemide, which has been shown to be quite beneficial in these patients. Okay, and combining these two drugs along with extending a sodium restriction diet, we can produce a nice diuretic effect. And then from pathophys component, do understand that when we talk about diuresis, especially aggressive diuresis with sodium restriction and the use of these drugs, we can actually produce volume depletion at a much faster rate than actually achieving depletion of peripheral edema. Okay, and so if you look up some of the management guidelines, they actually have some cutoffs in terms of how much fluid can a cirrhotic patient lose in a given period. And if I remember correctly, I think it's half a liter within a 24-hour period. But obviously check that guideline because it may have changed in the last couple of years. Antibiotics, basically we can supply antibiotics to treat some of these bleeding problems that can occur in some of these cirrhotic patients. We're going after kind of preventing spontaneous bacterial peritonitis, and so you can get kind of a bacterial infection within the peritoneal cavity. The drugs that are mainly used for this include a third-generation cephalosporin like ceftriaxone, fluoroquinolone, and maybe ciprofloxacin. Okay, and so you can see these antibiotics being implemented as they're needed. And then finally, lactulose. Basically, what we're trying to do is prevent hepatic encephalopathy. Remember, lactulose is a sugar. Specifically, it's a non-digestible sugar, and it's basically osmotically active. It draws water into the colon, and it basically allows the stool to be more soft and easily passed. And there is some stimulatory components to that, and some of that might come to the fact that there's a lower colonic pH, and you see a conversion of ammonia to the ion ammonium. And so lactulose is really kind of an important tool in the cirrhotic patient. And then finally, this particular patient had a history of alcohol dependence. So this is kind of a nice introduction. I'm just going to go over 3 different drugs that are routinely used to treat alcohol dependence. We're not going to dwell on the mechanism of action because we haven't covered any of these receptors, really. So the first one is naltrexone, which was originally used for, and still is, for opioid addiction. And it's going to kind of attenuate or reduce the reinforcing effects that are associated with alcohol dependence. Naltrexone and acamprosate are kind of your first-line drugs. Acamprosate, we're not really sure how it works, but we know that patients that are on it have a reduced craving for ethanol, which is key to their management success. Acamprosate might work through some of those receptors that are listed there. We'll talk about those in the CNS block later. Kind of the second generation or the second tier in terms of its use is disulfiram. And this is an enzyme inhibitor specifically of alcohol dehydrogenase. And if patients take alcohol and they're on disulfiram, it leads to an accumulation of acetaldehyde, which produces a very unpleasant reaction when ethanol is on board. And so it actually produces a conditioned response to alcohol. So previously they would get kind of a euphoric type feeling when drinking. This particular drug, if they do start drinking again, makes the whole process and the whole experience very unpleasant. They don't like feeling like that. It's worse than a hangover. We'll go through some of those side effects and what accumulation of acetaldehyde does to the body. But it produces a conditioned response. And so think of, Pavlov's dogs. Instead of a positive conditioned response, it's kind of like a negative conditioned response. And so patients don't want to start drinking again when they're on disulfiram. So these are the kind of the management strategies. I think from a clinical standpoint, it kind of makes sense to bring these up. And a lot of these drugs were discussed in the case. And in some cases, this was the introduction to some of these drugs, at least with the alcohol dependence drugs. But just to kind of consolidate your learning, the bulk of the pharmacology content was really kind of focused on the biotransformation, the metabolism of all drugs, specifically the CYP enzyme system, because it was so important in terms of liver physiology. Okay, but this is clinically relevant, and I just kind of wanted to put this out there. All right, thank you.